Our next speaker is Dr. Bader Al-Mas'ad. Dr. Bader is a graduate from Ireland, from Medical School Ireland, and he did actually he's in neurology. Dr. Bader is one of the excellent neurologist specialist in Kuwait, one of the excellent clinical tutor actually in the Kuwaiti neurology program. Dr. Bader is he's the first batch actually of Kuwaiti neurology program graduation. We're really proud of him actually, Dr. Bader. And Dr. Bader today will speak about treatment of idiopathic diagnosis and management of idiopathic intracranial hypertension. Dr. Bader, the floor is yours.
So good morning, everyone. I would like to thank Dr. Jassim and the organizers for inviting me to speak here. So we'll talk about intracranial hypertension, or as it was known previously as pseudotumor cerebri. It was also known as benign intracranial hypertension, and most lately as idiopathic intracranial hypertension. So as you can see, there was many terms used to describe this disorder, and it may suggest that there was some confusion regarding the cause of this disorder, and there still is some confusion. It is a disease of middle-aged obese females usually, so that is the typical patient, and that is when we term it as idiopathic intracranial hypertension. So the annual age-adjusted incidence in 15 to 44-year-old females was found to be 3.3 per 100,000. Now, if you do the same with obesity, so that would be patients who are 20% above the ideal body weight. It was found to increase the incidence to around 19 per 100,000. So as you can see, obesity is highly related to this disorder. Now, these patients usually present with headache, okay, so it is more common in obese patients. Sorry for the delay. More common in obese patients, as we said, in obese females, and typically they present with headache, pulsatile tinnitus, and transient visual obscurations. And as you can see, headache. Some patients may present without headache, so it's not all patients that have headache. In this slide, you may see this graph. You can see the incidence and over the last couple of years. So as you can see, 2002, the incidence per 100,000 was around 2, and this has increased, more than doubled over the last 15 years or so. And in the lower graph, as you can see, in the purple is the female patients, blue is male patients, and with increasing incidence of obesity, there is increasing incidence of IIH. However, that was not the same with male patients, and this may suggest other other causative factors such as hormonal profile. Another thing is as you can see here, it's more common, as we said, in the middle-aged. Pointers. Okay. So what is the cause of IIH? It is still not completely understood. We know that it's more common in obese patients, and this may be related to obesity being a chronic inflammatory disorder with the release of cytokines, adipokines, leptin, which has been found to be increased in the CSF of IIH patients, and other enzymes. In addition, obesity may lead to venous stasis and increased venous pressure intracranially. We'll talk about that later. So it's either increased CSF production or decreased CSF drainage, which lead to high ICP. A postulated mechanism for decreased CSF drainage would be that there is, as you can see here, this suprasagittal vein may have elevated pressure due to distal obstruction, even down in the neck, or due to obesity. There is there's increased pressure due to the compression on the pleura and the cardiac vessels, and this may go up into the suprasagittal sinus because there's no valves in the draining veins, and this may lead to high pressure. This will lead to decreased absorption of the CSF to the arachnoid villi. So obesity can lead to IIH through many different mechanisms. As we said, increase in abdominal pressure may lead to reduced CSF absorption through the arachnoid villi. Obesity can produce a hypercoagulable state, which may lead to occult cerebral venous microthrombosis, and this may lead to reduced CSF absorption. And then there's many hormones that are secreted from adipose tissue, including the mineralocorticoids, which may ultimately lead to increased CSF secretion. So what are the symptoms of IIH? We all know that it can cause headache. The headache characteristic varies, but it usually is insidious in onset, and it is progressive and continues to become more severe, present in the majority of patients. Visual obscurations are described as sudden darkening of vision or blurring of vision by the patient. They are exacerbated by movement, for example, praying or sujood or walking. And it's quite specific for high ICP. Pulsatile tinnitus would be a pulsating, whooshing sound like a heartbeat in the ears. And then there's other symptoms, such as back pain, which may be radicular. Interestingly, they may have cognitive disturbance. In a 20% of patients, they will have cognitive disturbance, and this usually does not improve the treatment of the IIH. It may persist. What are the diagnostic criteria? So they are the modified Gandhi criteria. You need to have A to E. So headache with papilloedema, normal neurological exam, except for a sixth cranial nerve palsy, which is a sign of high ICP. You need to have the normal neuroimaging, so normal brain parenchyma, and you need to rule out venous thrombosis. You need to have normal CSF, and you need to have a high opening pressure, which we'll touch about later. This is just to remind you of the grades of papilloedema: 1, 2, 3, 4, and 5, with obscuration of the vessels, and starting in 3. And just as a note, always make sure that you don't have a case of pseudopapilloedema, which we commonly see. So always make sure that patient is, if you're not sure, to be examined by an ophthalmologist or a neuro-ophthalmologist. You can do an OCT and other tests. So there is an entity called IIH without papilloedema. Okay, this has been added to the diagnostic criteria. This is from the consensus guidelines in 2018. And you need to have criteria B to E with either a unilateral or bilateral sixth nerve palsy or neuroimaging findings suggestive of IIH. So at least 3 neuroimaging findings. And this at the bottom shows you the opening pressure. 25 to 30 is somewhat of a gray zone. If the patient is obese, usually we take a reading of above 30 to be significant. So why does IIH happen without a papilloedema? Why can, it's not clearly understood, but the proposed mechanism is that there is compartmentalization of the subarachnoid space here around the optic nerve sheath. You may get reviculations and obstructions, and this may lead to impairment of transmission of the pressure down to the optic disc, and so you don't see any optic disc edema. As you can see here in an example, there is asymmetric edema more on the left. You can see here in the T2 imaging that there is dilatation of the optic nerve sheath bilaterally, and this is a CT cysternography, and you can see contrast failing to transmit forward towards the optic disc. So there's something obstructing here. This may be asymmetric, one-sided, or bilateral. So these are the common neuroimaging features of IIH. As you can see, the first image, there is an empty cella sign. You can see here dilated optic nerve sheath. You can get tortuosity of the optic nerve. You can get stenosis, which commonly is seen with in the transverse vein. It's stenosis and not thrombosis. And you can get flattening of the posterior globe. So how would you diagnose such patients? You need to do a good ophthalmological exam, investigations. You check the visual acuity, color vision, formal visual field testing, and check extraocular motility, and do, of course, a fundoscopic examination to check for papilloedema and the grade of papilloedema. Should you do MRI, MRV, CT, or CTV? In most patients, usually we do MRI, MRV, and this is because MRV is more useful in detecting the other possible causes or differentials such as fistulas and any meningeal disease and the subtle signs of IIH. But in typical patients with IIH, a typical patient, so middle age, obese, CTV may, if that's what's available, it can be enough. Lumbar puncture should be done in the lateral position. Patient should be relaxed, extend the legs before measuring. Common associations that have been reported to cause raised ICP. So when you take a history, the most important thing is to check if the patient has a recent history of weight gain. This is a risk factor. If there is any hormonal imbalances. And of course, check for medications. So the common medications are fluoroquinolones, tetracyclines, which are given usually for acne or skin disorders, and the vitamin A derivatives. So you need to ask about that. If that is present, then of course we need to stop it. This is a typical visual field that you may see in a patient with IIH with an enlarged blind spot and the nasal step. Okay. This is another patient showing enlargement of the blind spot with peripheral constriction, and after treatment, visual field usually always improves after treatment. The normal visual field progression. Okay, so the steps would be enlargement of the blind spot. That is the earliest, most sensitive sign. And then you may get a nasal step, and this will progress to a visual field constriction with tunnel vision. So we'll go straight to management, where there are some issues and changes. So first thing in management, we need to have a general approach. So identify if there's any reversible causes and treat them, such as medications. And then check, the most important thing is lifestyle modifications, such as weight loss, low sodium diet, and then you have medical therapy and surgical. So we'll touch on each of them. This is just a way to categorize, or a table to follow. If you have a suspected case of IIH, you would usually start with weight management. And this is advised for all patients with a BMI above 30. You then assess, is the vision threatened or not? If the vision is threatened or the patient has fulminant IIH, you would go towards more surgical approach. So you would insert a lumbar drain and then either go to CSF diversion or optic nerve sheath fenestration. If there is no immediate threat to vision, consider medical therapy with acetazolamide and evaluate the headache. As we know, acetazolamide may improve the headache, but in many patients does not improve. So the headache may have phenotype of migraine or tension, and you need to treat it accordingly. And you need to identify if the patient has medication overuse headache, which can be common in such patients. And then the only disease-modifying therapy at present is weight loss. Okay, and it has been noticed that 6% weight loss is usually enough to improve the headache, and 10 to 15% may be able to induce remission. It should be offered to all patients. You should do a structured weight loss program, not just advise the patient to lose weight. You should give, for example, give them a follow-up with a dietitian or a weight specialist. This will ensure better weight loss. There is no recommendation at present regarding bariatric surgery. However, it is advisable to consider it if the patient is morbidly obese or unable to lose weight. And there is currently a trial ongoing called the IIH weight trial, assessing bariatric surgery versus diet. And they're following up visual fields and disc edema, etc. This is a meta-analysis or systemic review of meta-analysis looking at surgical versus non-surgical weight loss. And it is showing, as you can see, headache improves in more than 90% of patients if they're going surgical therapy, and in non-surgical therapy or diet, the headache improvement is around 20 to 30%, so it's much less. But keeping in mind that patients who underwent surgery lost more weight. Also, papilloedema improved in around 100% of patients who underwent surgery. So, but this is a small sample size, and still there is no recommendation regarding going for bariatric surgery or weight loss. The important thing is to lose weight, and if the patient is failing to lose weight, to consider offering bariatric surgery. So we'll talk about the medical therapy. The gold standard is acetazolamide or Diamox, which is a carbonic anhydrase inhibitor. And it inhibits the carbonic anhydrase enzyme, which is responsible for ion transport in the choroid plexus, and this will reduce CSF secretion and to reduce ICP. You can see it below in the diagram. Acetazolamide and also topiramate has a carbonic anhydrase activity. So is it recommended? What's the evidence for acetazolamide? So the current Cochrane review reported the following, that there are two RCTs which show modest benefit for acetazolamide for some outcomes. However, there is insufficient evidence to recommend or reject the efficacy of this intervention because there is still not enough high-class evidence for acetazolamide. An initial study done by Bal et al. Failed to show any significant treatment effect, and there was a high discontinuation rate. But the IIH treatment trial, which we'll talk about now, did show improvements. This was done in 2014. It's a multi-center, double-blind, randomized, placebo-controlled trial where patients were randomized to acetazolamide or placebo plus weight loss. So both did the weight loss program. And the primary outcome was perimetry, so visual field function, and then other secondary outcomes were disc edema, quality of life, headache, CSF pressure. Many patients did not agree to a second LP, but some did. This shows you on the first graph on the left, in the red, it is acetazolamide plus diet, and placebo is in black. So as you can see, this is a change in visual field function. There is a significant improvement in visual field function starting within the first month. So treatment has an effect immediately, usually. And this persisted. This was significant. And then the same thing with the optic disc edema. It's improved with the acetazolamide plus diet. And again with the acupressure. Just focus here on the right, the HIT score, which is a headache intensity score, and the visual acuity in this trial, in the IIH trial, there was no significant improvement in headache or visual acuity. So the maximum dose they used was 4 grams daily of acetazolamide, which is a big dose, and the majority did tolerate 1 gram per day. What we usually do is we start 250 milligrams twice a day or 500 twice a day, depending on the patient, and then you titrate up, usually to a maintenance of 1 gram, and you follow up the patient, and you can go up. that the patient is tolerating. The main side effects would include paresthesias in the oral, in the face and the peripheries, and altered taste sensation. They can get nausea, fatigue, and you should advise them to watch their fluids because they are at risk of renal stones. So what was learned from this study? This was the first proper RCT for acetazolamide, and it proved that it works. And the effects were independent of weight loss. It was controlled for weight loss. So disc edema improved, visual field improved, headache not so much. And the symptoms improved within the first month. And in this study, they did not supplement with potassium. There was no need for it. Other medications to consider are topiramate, which we know is used for migraine prophylaxis, and it has a carbonic anhydrase activity and can suppress appetite, which can help you with the weight loss. It has been compared to acetazolamide in an uncontrolled open-label study that showed they were equal. Furosemide, which is a loop diuretic, sometimes it's mainly used as an add-on therapy in low doses. So what are the surgical options? We know we have optic nerve sheath fenestration and CSF diversion, and cerebral venous sinus stenting. And these are usually reserved for moderate to severe visual loss or when medical therapy. There is no prospective randomized studies not to compare them, although there is one currently ongoing comparing VP shunt to optic nerve sheath fenestration. What is optic nerve sheath fenestration? The ophthalmologist would do it, and they would make incisions in the optic nerve sheath to allow pressure to dissipate through and the CSF to go out. This improves the visual. It's mainly done to save the vision in the eye, and this can have an effect in the contralateral eye, even if it's done on one eye. 1/3 to 1/2 have no improvement in headache. So this is not done. All surgeries are not usually done to improve headache. They're mainly done for vision. It has some complications such as hemorrhage, diplopia, and a higher vision rate. The preferred CSF shunt would be ventriculoperitoneal shunts rather than lumboperitoneal because of a lower chance of revision. It is effective in improving visual acuity, visual field, and papilloedema. Not so much headache. Complications of shunts, as you know, can be abdominal pain. You can get shunt obstruction, migration, low pressure headaches, which can be common. What about venous sinus stenting? So still not 100% clear if this is causing the IIH or because of the high ICP you get stenosis. However, there is a review that showed that with significant improvements in headache, visual symptoms, however, the sample size was small. So there still is no recommendation for venous sinus stenting. If you consider it, it's considered in medically refractory patients with clear sign of venous sinus stenosis on MRV. You need to do a conventional angio and make sure there is a high pressure gradient across the stenosis, and the higher the gradient, the more they will improve. Usually done unilaterally, not bilaterally, and you need to be on antiplatelets after it. And then how should IIH? We'll go through a few questions, common questions that we encounter clinically. So how should IIH be treated when there is an imminent risk of vision loss? So patient is progressively becoming worse, vision is dimming, and or there is severe presentation with severe constriction and so on. So the treatment would be surgical. Okay, so you should consider inserting a temporary lumbar drain, and then either optic nerve sheath fenestration or a VP shunt. And previously it was mentioned that you can use corticosteroids, still use sometimes, but there is no recommendation to use corticosteroids for permanent IH at this time. You should insert a drain as soon as possible and then choose either surgery. What is the best way to manage headaches in IH? As we said, it does not usually improve with the traditional therapies. So, and headaches can commonly have a migraine character or a tension type character. They are commonly have medication overuse headache because of the common abortives. So if you have an acute headache, you want to abort the headache, you can use NSAIDs. And then later on follow-up, if you want to reduce the headache, you can use the typical migraine preventative therapies. If the phenotype is migrainous, you should be careful when using therapies that increase weight gain or increased depression, because these are common comorbidities, so such as Inderal or Septizol. Topiramate would be a common go-to because of the carbonic anhydrase activity and weight loss. Should CSF diversion procedures be done to manage patients with IIH with headache alone? So only with headache. In that situation, that it should not be done, because as we said, they are not very good for reducing headache. So a patient with a shunt comes to you with headache. How should you approach? Is there signs of infection? Or if there is papilloedema and vision deteriorating, you should liaise with the neurosurgery and revise the shunt. If there is no papilloedema, or there is papilloedema but the visual function is stable, you should do an LP and investigate for other signs of headache. What about pregnancy? In short, it usually doesn't become worse with pregnancy unless there's a great weight gain. The use of acetazolamide is controversial. There has been some reports that it may increase the abortion rate. Topiramate also shouldn't be used. If there is a potential for a prolonged second stage of labor, you should consider assisted delivery. What about new therapies that are being studied? So GLP-1 agonists, which are used in diabetes, already established and available, have been shown mainly in vitro to greatly reduce ICP. And there's a pathogenic basis for this because it's present in the coral plexus and decreases CSF secretion. This is the last slide. There is another enzyme called 11-beta-hydroxysteroid dehydrogenase type 1 in the coral plexus. This converts cortisone to cortisol and is responsible for CSF secretion. There's already a trial that has nearly finished, which studied this molecule in a phase 2 randomized control fashion, and the results are still awaited. So this is a possible also new treatment coming. And I thank you for the time.